interesting for us is that in the Tyler community, you have a heavy population of African Americans, and Hidalgo County has a heavy population of Hispanics. And both of those populations really pose different challenges, right? I myself am a Hispanic woman who came from a very low income area in the state of Texas. And I was raised amongst a lot of nurses. The majority of my family are nurses. My mother's a nurse, my sister's a nurse. So being able to really see the disparities, I grew up in El Paso, Texas, so seeing the health disparities there and how that played out in the pregnancy outcomes was really important for me when I had this opportunity to work in this collaborative to then go and listen to folks in Tyler and listen to folks in Hidalgo and know that 50% of the challenge sometimes with our populations is the perspective they have about walking through a door. And that's a perspective that we really don't capture all the time when we talk about some of the programs and some of the packages that we have, right? We sort of get caught in the, here are the different things that we want to do, and which are important. I mean, it's critical to have expertise that knows how to treat patients, how to get access to care, how to diagnose what they might be facing. But there's that other element of all of us that really has to push ourselves to tie individuals to ensure that we're paying attention to what is the perspective of the folks and how do we get them in the doors earlier. So this particular collaborative, it's been working the last 2 years to figure out what do we do there. And also, so how do we dispel myths that individuals might have that keep them from wanting to come into a provider, into a clinic? How do we approach families out there to ensure that they understand waiting until 3 months before your birth is not good enough? We need you in earlier. And like Mrs. Dort said, and Dr. Earlier said, and I'm sure that a lot of the sessions have said, how do we have communications with folks out there to say, having better birth outcomes isn't just something that we treat during pregnancy, but rather it's a conversation that starts today, a conversation about just your overall health patterns and what you're doing to try to ensure that you have better health in general. So, so in terms of that project, it's really been driving a lot of the conversations that come back to HHSC as some of the partners in the various programs, including folks that are working in Medicaid or folks that are working in the substance abuse sections, in the behavioral health sections. I think a lot of folks have touched on a lot of the pieces that are coming out with this particular project, which is how do you treat postpartum depression, but really how do you treat depression, right? Because postpartum depression is incredibly important, but there's more and more studies that show that oftentimes some of those folks are experiencing depression on a regular basis throughout their entire lives. So how do we potentially have those conversations with folks, so that we can kind of address those sort of initiatives? So in terms of that project, we're really excited. We're moving into the second piece of that project, which is basically, the first was really exploratory, getting out there, working with the community, the stakeholders, really assessing what's out on the ground, what is the need, what is the perspectives, where do we want to head? And now we're narrowing that focus into what are the 4 or 5 things that we can do really well? What are those things that these communities can really focus on so that we can try to see what outcomes look like in the next 2 to 3 years? So if you spend some time at the front end of something, you have funding available, you put that funding out there, you try to determine where you want to head with it, you zero in on those things you really want to focus on. Reality is we could focus on 100 things. There's so many different aspects of trying to improve healthcare out there, and they're all really critical, and they feed into the overall final, positive health outcomes. But because of the way funding is sometimes structured, you really got to figure out what those 2 or 3 things are that you can really launch into and drive, that focus and figure out what those outcomes looked like. And then making sure that we get out there and we communicate those projects so that the other folks, I'm sure that as I look across this room, you all represent those other 100 things that we're not able to really navigate towards right now. But in being able to talk to you about these projects and then seeing what your responses might be, as in, here's a side note that you might want to think about as you focus on your 4, will be incredibly important for us. So what might be some of those 4 that we're focusing on? You know, I'll say some of the areas that we're really focused on with this project is making sure that there's access, right? So Hidalgo County, Tyler County, both of them become rural very quickly, right? So there's folks that have a barrier to health access of having to get 50 miles to their nearest provider. So, you know, Healthy Texas Women and Family Planning and BCCS, those are all programs that have really been looking to close those gaps by ensuring that we made ourselves available to as many folks as possible that could enroll in the programs to provide services. And, you know, in Healthy Texas Women, we have almost 6,000 providers across the state of Texas that are available to provide services. That's great, but how many folks know that, right? So we're really leveraging this collaborative in this particular project to ensure that we're communicating that out there with all of the different folks that come to these community stakeholder meetings. So, you know, making sure that access is there. Some of the other items would be, you know, what does it look like to have mobile health clinics? What does it look like to really examine what it means to have a functional mobile clinic that goes out, and for what purposes? So asking those communities, you know, what are the limitations there? What are the opportunities? So those are some aspects that are coming out of the project. And that's interesting for me to really talk about, because there's the core project, and then there's all these other things that are informing, you know, additional improvements that we're trying to make at HHSC under these programs. In terms of overall funding for the programs, we do focus, this is the one program that we do focus on quite a bit when it comes to quality improvement. On the other spectrum, what we do internally for the programs is we have a team of nurses who collaborates with the folks who are providing services under our regular programs. And that team of nurses is going out and communicating with the clinics on a daily basis, or definitely on a monthly basis as they do reviews, to also get feedback from the various providers on how we can continue to improve what we're looking at when we go out to the clinics, and what we're speaking about when we're going out to do training and doing a best practices training from a medical standpoint with that team. So, you know, so those would be the projects that we're really working on most heavily under the Office of Women's Health, you know, related to these 3 programs. Thank you.
Thank you very much. Would you like to stand up? Or? Sure. Okay, great. So this is Dr. Bob Hendler. Dr. Hendler provides strategic guidance and oversight responsibilities for the Clinical Innovation Department of the Texas Hospital Association, which develops and executes quality and safety projects for the benefit of the member hospitals of the overall association. He trained in internal medicine, so a little different, which is very nice, thank you, and gastroenterology at Parkland in the University of Texas Southwestern Medical School. He served 15 years as a vice president in Tenet Healthcare. Very important for us, because we talked about that earlier, about how insurance companies are involved with us today. And as the chief quality and safety officer during the 3 years with the Parkland Corporate Integrity Agreement and Improvement Process. At Parkland, he also served as the associate chief medical officer, senior vice president of professional and academic affairs. He is a previous trustee of the Texas Hospital Association and the Foundation, and he is a clinical professor of medicine at the University of Texas Southwestern Medical School. Thank you.
Thank you very much. I'm happy to show my scars from the time at Parkland for anybody who's interested. We did a lot of great work there, though. Let me start off by saying that
Forward, right?
that it's a real honor to be included. This started about 6 months ago when I was called and we began to talk about potential topics, and it's developed into this panel to be among these distinguished and expert speakers. But I also just want to say that I'm not usually in a group like this where I can really look out and say, everybody here is unbelievably dedicated. It's really a remarkable situation. I think this comes as close to what I consider doing God's work as you can do. At the THA, where I'm the chief medical officer and I oversee a group of incredibly dedicated nurses who will drive 7 hours to a small hospital where there's no dinner and no hotel to spend half a day working on quality improvement projects, and we do this. that it's a great privilege to work the past 6 months because I'm fairly new. We are providing clinical support, and we are really looking at developing, we don't have it yet, but we are looking at developing additional financial support to touch on what everybody's talking about. What are the holes as we go forward and we go further and further in this? What are the holes in the support for what you would need at your very many hospitals? So this talk has developed over the past 6 months, and like you, I'm kind of curious to hear what I'm about to say. So let's get into this. First of all, we talk about projects as, you know, setting up a straw man, and in this case it's a straw woman. But there's a proposal that to really have healthy babies and mama, I think that really boils down to access to care, period. I mean, everything else follows from that, mental health, depression, but getting to the right people and receiving the care is critical. Now, the burning platform, we all know, is the fact that our mortality rate in the United States is the worst among all of the developed nations, and that we have one of the highest mortality rates in Texas in the developed world. So the straw woman is a beautiful mama with a baby. The burning platform is that this mother died about 8 days after she gave birth from a pulmonary embolus. And this is the sort of thing that's incredibly tragic. So I'm going to walk through the things that seem to be important to me in setting up this talk, and some of this is very much reinforced by what I've heard over the past 2 days. We're last among the Organization for Economic Cooperation and Development, all the industrialized nations of the world. They try to normalize their data so it means something between countries, and you can see that Sweden does really well, and we're last of this. But I went a little bit further, and some of our American states are doing extraordinarily well. They've been focused on this for a number of years. We've learned a lot from them. California is doing as well as any of the industrialized nations, and we're not the worst in terms of deaths per 100,000 live births. Louisiana, Georgia, Indiana, Arkansas, New Jersey. It doesn't make us feel better. We're still in the bottom quartile, and that is certainly not where we want to be. But this just sort of puts it in perspective that there's a massive variation throughout the country. And now I've learned about Chicago, and I'm going to really be studying Illinois in terms of what I can bring into our work, and I'm sure many of you will be doing the same. For every woman who dies, it was mentioned earlier, the previous number was 50 to 100. The data I came up with is that for everyone who dies, 70 more come close. And you can see in this summary of some data I went through that the frequency is increasing, 200% for pulmonary failure, almost doubling for cardiac arrest and shock. That this is truly continuing to worsen, and all the data seems to stop about 2014. This is Samantha Blackwell, and a few days after her delivery, she had severe sepsis and had to be put into an induced coma, I believe for nearly a number of weeks, but she did survive. Now, the easiest approach to quality improvement, frankly, is to be in Texas A&M. It's the cheapest way to do it. You're going to get some free help in setting up your QI. You're going to be focused in standardizing care across the state. And ultimately, if we can really develop this collaboration where we're truly helping each other and communicating with each other, we'll see the same thing that you're seeing in Illinois. So I'd like to focus, number one, on saying the really unique and innovative quality improvement, cost, needs, assessment, and everything else is actually what we're already doing. So I don't think we have to develop a lot of new things. We go down this road. We have 207 of the birthing hospitals in the system. Birthing centers will be added, I'm certain, and you can get that mentoring, that best practice, and I'll focus a little bit on the early warning systems as something that we should all add to our QI projects immediately, build our teams, and then the data acquisition, which you heard so eloquently again from Illinois, data that comes in and is available to you immediately. I've never been able to do that, and I've been in a lot of systems over a lot of time, so that's something I'm going to be focusing on. And then stepping out into the community, you've heard about that as well. So the Texas Hospital Association Foundation nurses are there. Many of you, I hope, they have contacted you or been in touch with you, or you have been on the WebExes or some of the visits, but we really are there to serve our 452 hospitals in Texas. And you've seen this, but this is the rate of hemorrhage, but it says how bad was the hemorrhage, how bad was the severe maternal mortality. And again, you can see variation, massive variation, which means we haven't got our bundles out there in a standardized fashion to make it work. And you've seen this slide as well, that this is a delayed response to clinical warnings. I think this is a tremendous first step and should be a priority as we do our AIM bundle, then we go into hypertension and other things. But I think this is sort of the beginning step. If you don't know what's going on, if you don't have the report, the connectivity, the doctor responding, then we're not going to be as successful as we can. So, determining need. What do you need? Well, after AIM is done and you've been working on this, there are going to be holes in here. Now, I've made up a few things, but it might be getting the data you want, or having an analysis done of local information, or for the hemorrhage. I mean, how many small hospitals are going to have trouble paying for a hemorrhage card? I'm sure there's many, many, many things there. How many want to learn about simulation or go get additional education? Those are things that are not typically covered in the standard grants. We have tremendous support from the state in all of these areas, but I'm going to talk about the holes in the cheese. And classic, this is the brief part of it that I'll talk about QI, but you have to put together the old classic quality improvement AIM statement or charter, and you have to be really, really precise about what it is you want to do and how you're going to sell it, because you got to sell it to your boss, and you got to sell it perhaps, as we go further, to somebody in your community. Cost, first of all, I'm not going to teach you how to do that here, but you may have those resources in your system, in your finance people, in your board of managers, people who can say, what do I need, and I can put a number to it. So again, I'm not going to focus on that today. But I do want to focus on the Muse, and again, in terms of the needs, you may find, in this particular case, Kristen passed away 6 days after a VBAC, again from a staph infection. You may find in your community that you may see a donor who's related to a tragedy that wants to do something to make sure it never happens again. So we're looking for atypical sources of revenue. So here we talked about the wonderful 207 hospitals, but here from your own data, you only have 33 hospitals that are involved in the Muse project. And so this is why I think it's a critical area to do that. And by pure happenstance, Ms. Stewart's discussion about Kira, here's Kira Dixon, who passed away with her husband Charles and their first child. She died 12 hours after delivering her second child, and you already heard the story. Everything we're talking about here has a tragic, palpable, human component that we would like to see never occur again. So, determining cost, again, very, very briefly. What do you have? Look at your internal resources. You may be surprised you have more than you think. What do you need? Do you have existing staff or board members who can help you put together an ROI or some other kind of financial deal? Look up the cost of equipment, whatever it might be. And then you have to cost out people time. And again, with AIM, we have a tremendous amount of people time that we're just doing it as the routine part of our care in our hospitals. There are many fundraising resources. I'm going to skip over a little bit of this because I think I'm going to leave it to Elizabeth after I talk to her about grants. That she'll probably go into this, but I do want to mention that right here, you know this webpage, our folks here from the state, there are web pages at the state helping you find funding. So be aware that that exists. It's out there. But there are obvious sources in your community. For example, communities foundations, I did not realize, are every place. But you have to see who that community foundation is and what their scope of support is, because they may have their own governance system and saying what they will and they will not do. But they can clear house for grants and grant makers. They can vet certain projects. And there is a reality. There are people in your community who want to fund you but don't know who you are. And so I'm turning this over to you to say you're going to have to go out and find those people and convince them to help you. There is local money looking for you. There are individuals interested in supporting your concern. Here's a list of some of the community foundations all over the state, which I was not aware of until I got into this project. And there are many, many more. But there is no guarantee of funding. You know, you must convince. So you start off with Texas AIM, I would say. You work things, you still have a problem. You define it, you put it in a convincing form, you cost it, and you go out and you present it. And you present it to various people. Some of this is grants, but some of this is person-to-person stuff in your community. And you take that forward into an initiative, hopefully with any number of atypical sources of revenue. So in summary, I just want to say, you know, we want to have healthy children, we want to have healthy babies, and so I just throw in a picture of my grandchildren, because we've been fortunate. And with that, I will stop and then we'll answer any questions.
Thank you. Our final panelist here is Elizabeth, as Dr. Hendler referred to. Elizabeth Krause is from the St. David's Foundation. She leads the foundation community investments in 5 portfolios: women's health, opportunities to be active, health insurance enrollment and use, access to healthy food, and adult dental. And each of those touch women, so we're very thankful for each of them. Thank you. Prior to joining St. David's Foundation in 2016, she spent 11 years advancing health equity with the Connecticut Health Foundation, where she concluded her tenure as Vice President of Policy and Communications. Elizabeth began her career at the CDC, where she completed rotations with the National Center for Injury Prevention and Control, the CDC Foundation, CDC Rwanda, and a field assignment with the Colorado Department of Public Health and Environment, where she was instrumental in starting up the state's Office of Health Equity. Elizabeth graduated cum laude in Phi Beta Kappa from Smith, earned a master's in social and behavioral sciences from Harvard, the Chan School of Public Health, and she serves on the board of the National Asian and Pacific Islander American Health Forum. Thank you very much.
Hello, everyone. Thank you for including me in this wonderful summit. St. David's Foundation is based here in Austin, and we fund in the 5 counties of Central Texas. And our BHAG, our big, hairy, audacious goal, is to help make Central Texas the healthiest community in the world. But we know that we can't become the healthiest community in the world unless we have healthy women, healthy families, and unless we address the inequities that some of our neighbors experience. Okay, so when I looked at the title of this panel, novel ways to fund your quality improvement project, I got a little existential. What do they mean by novel? Is anything I have to share a novel? Spoiler, perhaps not. That does invite the imagination to run wild a little bit. I thought, it's Girl Scout cookie season, so what if we kind of took on the Girl Scouts and developed our own quality improvement lactation cookies and sold them, and the revenue could go toward quality improvement projects? Could work, right? I mean, they have a pretty good enterprise going, but that could be a disruptive innovation. And then, whose idea of quality improvement? I like to think of quality improvement holistically. So yes, we've talked a lot about quality improvement with a capital QI. So, and all the alphabet soup, the IHI, the PDSAs, the AIM. But I also know that there is room to improve the quality of the perinatal period and birth outcomes in a more holistic way, in a way that really speaks to how patients and mothers would define quality. I spent 2 years on the state of Connecticut's Quality Council for their State Innovation Model grant, and so I spent a lot of time looking at quality measures that were going to feed into a balanced scorecard that would be tied to a value-based payment. And I served on the council as a consumer representative, and I did see the disconnect that can happen, it doesn't always happen, between where there are validated measures that we can tie to payment, for example, in healthcare delivery, and how everyday people would kind of describe what quality means to them in their healthcare encounters. And the nice thing about sitting at a foundation is that I can be open to having conversations about all dimensions of quality with the different stakeholders and players. The exciting news is I think there are a number of private foundations that are kind of stepping up, both in Texas and nationally, to play a role in improving the health of mothers and babies. We've talked a lot about what's going on in California, and what you may not know is the California Healthcare Foundation has been key in supporting the Data Institute that has contributed to some of the success that that state has had. Here in Texas, St. David's Foundation has been investing in improving the postpartum period. We know that our sister foundations, the Houston Endowment, convened stakeholders in Harris County to come up with a plan to address risk factors for maternal mortality in that part of the state. On the early childhood side, the Episcopal Health Foundation, also based in, not Dallas, Houston, yes, thank you. But they fund in over 50 counties, including up into Central Texas, so they have a pretty big region. They just announced over $3 million to strengthen early childhood brain development, and some of the grantees, if you go and look at the list of the organizations that were funded, kind of work with neonates and new moms, and so there is a lot of exciting work going on. I think what's kind of implicitly come up is that there tends to be artificial divide between women's health and early childhood work. And I think you would find that replicated in how funders organize themselves. So you will find that there are women's health funders or women's issue funders, and there are early childhood funders who kind of work in the 0 to 5 space. And every once in a while, the twain shall meet, and you find funders that address maternal and child health. Even at St. David's Foundation, I lead our women's health work. My colleague Kim McPherson leads our work looking at a child's first 100 days of life, and that's just a new, more accessible way of talking about what we used to call birth to 3, but she's really looking at how we help families address childhood adversity and childhood resilience. And we know that there is overlap in our work. We've still kept it as distinct areas because some work is truly women's health, some work is truly early childhood, but where there is overlap, we try to be very thoughtful about how we collaborate. So when a mother experiences intimate partner violence, is that a women's health issue, or is it a childhood adversity issue, or is it both? Or when a home visiting program starts with visiting pregnant women and then goes into the second year of the child's life, is that a women's health initiative? Is it an early childhood initiative? Is it both? And I think we can really kind of hone in on where that sweet spot is. Okay, there is an adage in philanthropy that if you've seen one foundation, you've seen one foundation. I would love to know who said this originally, because that is our Yogi Berra in the philanthropic sector. I don't know who said this, but it's true. And so while I was thinking I could get up and talk a lot about St. David's Foundation, because y'all are from every corner of our state, and some of you are visiting from other states, that wouldn't be particularly relevant. So I wanted to talk a little more generally. I think as you're kind of prospecting, and that can be one of the most intimidating aspects of finding foundation funding, first establish that a foundation that you're going to approach either funds in women's health or early childhood, and that there's that initial level of alignment. But 3 important screening questions are: what is the foundation's role? What does the foundation actually fund? And am I eligible to apply to that foundation? So in terms of the role, different foundations play different roles. Some foundations really want to set their own vision and agenda, and other foundations want to respond to needs that emerge from the community. Some want to invest in new exciting models, Others want to identify models that are evidence-based and successful and really implement, scale, and sustain them locally and not do that front-end work. What does the foundation actually fund? Some fund more charitable work, some will fund access to services and programs. Others are looking to get more involved in systems transformation, research, data, and I think those are ripe foundations to approach if you have a more traditional quality improvement project. And then the am I eligible question is really important. Most of us grant to either nonprofit organizations or public entities. And if you're not in a nonprofit, that doesn't mean you can't partner with foundations. There might be an organization in your community that you can work with that is a nonprofit and eligible, and we are always looking at where there are opportunities to partner more on the private side. Foundations also have their own criteria that you will have to sort through. St. David's Foundation is not a conversion foundation. We actually still own part of St. David's Healthcare here in Austin. We are not a traditional hospital foundation either, but because of our role in hospitals, I do have some bad news for Robert. We can't really fund hospital work, unfortunately. So there's some caveats to that I can talk to you about offline. But while we, as women's health stakeholders, think that immediate postpartum LARC insertion is super important, and we think the AIM work in Texas is tremendous, it's not really our role to fund that work directly. But where that work has dovetails into the community or the safety net, we can talk. So this is as novel as I'm going to get, aside from the QI cookies idea. So somebody once described a cartoon to me, and I've never been able to find this cartoon. I'm going to describe it to you. If anybody can actually find the cartoon and deliver it to me, I will reward you handsomely with a cup of coffee or a glass of wine, your choice. But the cartoon, and I picture it as being a New Yorker cartoon, I have no evidence of that. It depicts men in a high-rise building with bags of money at their feet, with an open window, tossing money out the window. And the caption says, "Oh, that's how the Ford Foundation does it." If only. That is not how we foundations operate. But I think, what people first think about, rightfully so, and for obvious reasons, is the funding in the form of grants. And we have different grant mechanisms. We can kind of talk to you about your ideas. We issue our own ideas in the form of requests for proposals and special calls. Many foundations have small grant programs that we can issue on a more nimble basis. And then we also do sponsorships. So St. David's Foundation is a sponsor of this summit. It is a very small contribution, but in some ways, I would like to think we're supporting all of your quality improvement projects when you get to come here and learn and have a positive experience. But on the lesser considered tool side, we have other ways that we can support organizations and projects. And we don't always do a good job marketing these resources that we have, and a lot of times folks don't know that we can work with you to convene stakeholders to try to solve a problem. We can introduce you to new partners, especially in the community. We might be able to have a scholarship that somebody can apply for to kind of build the next generation of clinician doing this type of work. And then yesterday, Dr. Lakey mentioned that we have recently funded the PATH project with TCHMB, and my time is about up, so I won't go into detail about that, but St. David's Foundation is super excited about that partnership, and we look forward to building the relationship for many years to come. So thanks, everyone.
So I'm not sure if we have time for questions. We do. Okay, so if there's any questions, if you could go to the mics, that would be great. And just while you're getting up, I just want to put a plug in for each of you. This was fabulous. I want you all to know that we were not rehearsed and everything went perfectly, just the way we liked it. So that means that we know how to run this conference, right? And then we know that hearing from everybody is really, really important. I I don't see any questions. One thing I'd like to add is that for DSRIP, I think the mystery of DSRIP is that people believe that in order to get monies for the people who are participating, that you have to do all and be all to everything. And I think that that's really something, if you could speak to that, Noelle, because it is a different payment scheme, and so that means everybody should join in. So if you can just outline that just a little bit so people understand how that aligns with other initiatives, such as what Dr. Bum talked about with LARC and the March of Dimes.
Sure, I'll see if I can try to get to that, and
If you don't, we'll just
if I don't, you can help me.
caption that. Yeah.
Is the question sort of like how everyone can participate in the existing DSRIP structure, or?
Okay, so
Sort
I'll
of.
say it, and then Noelle can say yes, that's correct or not. So if you have to achieve a certain element, so we're going to talk about reducing the first C-section. And
Yeah.
every time we talk about that, everybody groans because how are we ever going to reduce that now by 10%? But you don't have to do 10%, you must do something. So there's partial.
Right, so we have probably, I think, the number's either 15 or 20 hospitals that have elected, it's an optional measure, so within the DSRIP program, there's a lot of customization of what you can do. So we have some providers who have said, this sort of aligns with our priorities, and we have room to improve on this. And so we have I'm going to go with 20 hospitals that have selected to reduce their cesarean section rate over the next couple years by a certain amount. So they have sort of a target goal in order to earn their full valuation. And so this particular measure, and under this sort of DSRIP pay-for-performance structure, gets a specific value associated with it. And some of that money can be earned just for tracking it. We know that the art of reporting is really critical, and the practice of reporting and sort of the daily work of being able to understand what your performance is on particular measures, where you have opportunities for improvement, and specifically, where you have the most opportunity to improve. So being able to subsect, you have a 35% cesarean section rate, and maybe some of those are more preventable than others. So I think a thing that I like to emphasize often with DSRIP is that we're not asking for perfection on anything. We're asking for these incremental improvements, and that there are financial incentives really for the incremental improvements. I think DSRIP is unique in that I think looking at your slides, I think where you have an idea and then you try to find money. DSRIP is maybe the only thing I've seen where you get the money first.
Yes.
And then you're trying to, be ready to use that money in the best way possible. And so I think having the work done ahead of time for folks of like, what are our needs, and where do we have room for improvement, and where can we really use this money to address things that are really of critical value to the population that we serve and to our community, and then being able to use that money for its best resource. But it's I think generally in this particular pay-for-performance context, there is still reward for closing some of the gap, and did that sort of get at what you're trying to say?
Yes.
Okay.
And Dr. Hendler
So
has a comment.
the only difference is, it's a difference between grant
Yes, sir.
raising and fundraising. They're
Yes, sir.
different things.
Great. So get involved, pay attention, don't leave money on the table. And we have a question, please.
I was just wanting to share my story. I appreciate this segment talking about fundraising and ways of creative ways to find funding for your needs on your unit. I represent a small rural hospital in Kerrville, Peterson Regional Medical Center. And actually, it was the Peterson Foundation that came to me this year and said, every year at the end of the year, they send out letters to donors in the area looking for tax shelters. And we're dedicating this year's fundraising to your department. And I was just so excited. They wrote a letter, and they told the story of what we're going through in the state of Texas. A lot of the people in our community don't know about the problem that we've had with morbidity and mortality in our state and what we're being held to and to improve. And so we told the story. The other thing that the director of the foundation told me is babies and mamas are great fundraisers. We need to leverage that. Who, as a community wealthy person who's looking for somewhere to put their money, it's a soft spot. Mamas and babies are soft spots, so we need to leverage that. But their end of the year campaign for our hospital was able to raise $37,000 from my department this year. So I'm so excited to have a little bit of money to spend on a simulator for my department that they're kind of expensive, the mannequins, and they also are funding our infant safe sleep, the sleep sacks for us for the next few years and stuff like that. So tell your story. There is a little bit of money out there to be had. And the other thing I wanted to encourage us all, if we are at the end of the year looking for places to put your money to, I mean, you can give it to the IRS or you can give it to your local community foundation, but asking us as people who are in the know about what the needs are out there, donate to your local foundations. Thanks.
Can I add some color to that?
Yes,
quickly?
please.
So thank you for raising that. I think a perception may be that it's my job to sit in my ivory tower and wait for somebody to knock on my door, but it's actually my job to go out and find the organizations who can do the type of project that aligns with our objectives in the community. And so that's kind of what brought us to TCHMB. And so I just wanted to share, first give a plug out to the Texas Women's Healthcare Coalition. The staff are all here today. I was at one of their meetings and TCHMB was presenting, and I said, oh, I need to know this group. And so I set up a meeting with them after the fact, and we had just closed a funding opportunity. It was through an RFP where we funded 10 organizations with $2 million to address postpartum care and disparities. I see some of my other grantees here in the room. But you know, we didn't know who we didn't know. We're a relatively new women's health funder. So you know, sometimes the people you know, there's those you don't know, and then there's the, gosh, I didn't know them, and they kind of fell in that category. And so even though the RFP had already been fully funded, all was not lost because we were able to see how much alignment we had between organizations and to kind of co-create a project that we were all really excited about. So I just wanted to send out that message to kind of bring visibility to how we really work.
That's great. Any other questions? I just want to actually give a plug to one person. Viveca, you said something really, really important. Walk through the door. What does that look like? I think that each of us, it doesn't cost any money. It doesn't, a little bit of time, a little bit of secret shopping. Watch the entrance to your office space, your triage area, your main hospital. How inviting is it to women and their families to come? And when they say, I need a little help, or I'm not sure what I want, bracketing, like we said, the eye roll, the stepping back, the quiz show, as I call it, the 20 questions as they come in. If we could all do that one thing, we would increase access instantly. And we all say we don't do it, but I'm telling you we do it each and every time when a hospital calls another hospital and says, I'd like to transfer a patient. It's a quiz show. She's pregnant. She has a need. Yes, we will take her. It's a neonate. They have a need. We will take her. And then ask the questions of the right care, right place, right time. So that one question, another one key question for our people that are on that team would be, what does it look like when you walk through the door? So, yes, please. Yeah.
If I could just add one thing real quick. I really appreciate hearing from all the folks up here because I do think that sometimes it's difficult for us because our funding avenues are a little bit limited in our program. So what we really do, and I just want to share it real quick, is we're actually launching different variations of awareness trainings. And a training that'll be coming up in the next 6 months is going to be a human trafficking training. And what that training is we're going to go out to the providers and we're going to ask questions that really push the envelope of What does it mean to be in your community? And what does it mean to identify certain victims or certain potential victims and open that door? And that whole training is actually wrapped up in also what does it mean to identify these early entries of care? Like, how do we grab that population to bring them in? So while we can't always offer a lot of funding that might be available for some of the really incredible projects that these folks are working on or that these folks are able to fund, and just the same as multiplying that conversation with the private foundations, like there's leverage there that we don't necessarily have. But the leverage that we do have, that we will always have at the state level, is being able to get in front of communities, being able to get in front of folks and break down some of the perspectives and the barriers to try to get them through that door. So, you know, we want to do that in whatever ways that y'all can help us to do that. Please know that that's really our primary focus lately. So,
It's wonderful. Thank you. Thank you.
Okay, so just wanted to let everybody know we have a longer lunch today. We will be going to the same place for lunch. I believe we will be a little bit less crowded today. The conference that was next door is not there. So if you can come back here by 1 o'clock, we will be starting our next session. The other thing I wanted to announce again is for those folks who are part of some Muse conversations around QI project that had already been contacted, if you can bring your food to room 108, and there'll be a meeting that's starting there. It's a lunch meeting. Thank you. Oh, and just because folks outside had conversations, the slides are going to be available. The recordings are going to be available. So I know that folks want the slides. We will be providing them.